Right, there you go.
Thank you. Colleagues, good evening. Let's just give a couple of minutes for everyone to be in the webinar, and then we shall fire away. For those who are just joining, good evening. Give us a couple of minutes. We're just getting everyone into the webinar, and then we shall give a start to this. I will just give 2 minutes, and then as people keep joining, we will give a start nonetheless. So please bear with us. Right. Many colleagues today will have noted that this is the very first time that we are holding this webinar on the second Wednesday of the month. Holly, do you want to take down this holding slide? Traditionally, we always hold this webinar on the third Wednesday. And since I was aware that I would be indisposed for the next Wednesday, I went out to get some feelers from many of you on whether I should just cancel this or move it back by a week. Very kindly, an overwhelming number of you suggested that we will move it back by a week. And I'll be honest, I was slightly skeptical because, you kind of wonder if we'll have enough number of people. People are used to the third Wednesday. And then the registration numbers started mounting up. Interestingly, we had just shy of 300 people register for this webinar today. And so it filled my heart with joy. Today, I want to start this webinar by saying thank you to so many of you who make it such a joy and a pleasure to run this webinar on a monthly basis. I put in a lot of personal time and effort into the webinar, and you just make it so worthwhile by showing that enthusiasm, that excitement, that exuberance. It just makes it so worth it and makes this webinar something special where you feel we're making a difference together. Good evening, ladies and gentlemen. I am Dr. Mohit Venkatram. I am the Deputy Chief Executive of Northeast London Foundation Trust, and I'm the host of this webinar, The Future of Primary Care, which you are logged into now. As a very, very large provider of community and mental health services, we are very cognizant at NELFT that unless we work very closely with our primary care colleagues, our ability to provide robust, helpful, supportive out-of-hospital services for our residents would never be very effective. And while working with such amazing colleagues, it has been such a pleasure to learn throughout with them the way primary care functions. A couple of weeks ago, I was with colleagues in Havering, the Havering GP Federation, all the GPs, the clinical directors, as well as their chief exec of the federation. And this reality dawns on you when you speak to them, how passionate the primary care colleagues are in wanting to make a difference, in wanting to work with everyone else so that the residents get the best care. But it's really not lost on you that despite this enthusiasm, the equitability of resource sharing between primary care and other sectors of health service does not quite exist in the same way. And this webinar series, when I developed, was one such approach to say, if we shared part of it, if we learned together, if we grew together, would we be in a place that this learning opportunity would change how we work and jointly provide better services for residents. And one then wants to step back and think, so what is the barometer you would use to say primary care is working hard? How do you identify that colleagues in primary care genuinely are providing good services? So the NHS Digital often publishes some really good data on delivery from each part of the sector. And having looked at the primary care figures, which were just released for December, so you can imagine the lag because we're in February, so January will come just towards the beginning of March. So the December data has been published. Now, December is a really, really special month because, as many of us know, it's a month of celebrations, it's a month of fun and festivities, but it also means it's a month with fewer days, working days that are available for people to do the same job which needs to be done. December is also very crucial because it is just hitting that winter period. It's the time many people with long-term conditions like asthma, cold would have long leaves. So they want to make sure they have got enough medication stocked so that they don't end up in A&E. You want to make sure inhalers are there with you. So your call on your local GPs is much higher. In that month alone, despite fewer working days, primary care delivered 28.4 million appointments in this country. Now, many of you know I was talking about the challenge of managing your health, being on top of your medication. So the big barometer you want to use in that 28.4 million is how many appointments were given for the same day so that you could actually say on the 23rd, I need to make sure I've got enough medicine so that my family is safe, my elderly relatives are safe. Surprisingly, 46%, which is nearly half, so just over 13 million appointments were same day appointments that were delivered by primary care. And that makes you stand back and look in awe at this sector and say, what amazing people work in this service to make that difference. Now, the part of it that made me feel slightly sad was that only 90% of the appointments were attended, which effectively means we lost about just shy of 3 million appointments. So instead of 28.4 million, it could very easily have been 31.4 million appointments had all the appointments been used by us effectively. Now, one of the metric I have often come across colleagues say that, and my parents say it, okay, my dad says it, well, I'd like to have appointments face to face. This online nonsense doesn't work for me. So I was looking at the data to say, did primary care live up to our expectations? 67% of appointments in primary care were face-to-face appointments. So which means 2 out of every 3 appointments was done face-to-face for something which in the order of 30 million appointments, so 20 million roughly of them were done face-to-face. It does make you want to sit back and think, my God, if a sector gets one of the lowest payments, delivers such high turnover, how do you get such an important part of the health service, something that's so close to all of us, deliver better services, deliver more effective services, deliver better quality, deliver better productivity, and most importantly, deliver better outcomes for our residents? Now, one way of doing that is, of course, getting people to work even harder. But we know that's really not the answer. There's only so far you can stretch an elastic band. So in today's digital world, in today's world, when AI is really what people are looking at, the question arises, how do you use the digital tools that are available? How do you use AI? How do you use social technology so that you can maintain the sanity of staff who are delivering such fabulously important services so wonderfully well and yet improve care. Now, there are very, very few GPs I know who have both the passion for technology and the gravitas to carry the weight that says, I have done it. I have the metal and I can prove it. Our guest today, Dr. Tal Mahmud, is one such GP. And I could wax lyricals about him, okay? He's been a GP for 25 years. He's been on the board of commissioners. He's been on the board of providers. He's worked in GP federations. He has won number of awards and accolades, and I could spend the rest of the hour running them down. But I'm sure you can have a look at the internet and you will know we have someone of real, real importance who can talk to us with real experience of how technology can make a difference to the way we provide innovative solutions. Now, Tal's led a number of projects about productivity, about improvements. But the reason I was really drawn to Tal, and for those of you who know me very well, I feel very strongly about social inequalities that exist in our society. And Tal was one of the few people who I had met who had used social media and the power of webinars to improve and make a difference to social justice and social inequity. But before I hand over to Tal and welcome him formally, if I may just remind colleagues, we have almost 300 people registered on different platforms who will be logging in. Last month, our webinar was seen after post-webinar inclusive by almost 2,000 people. So please use the Q&A button on your Zoom platform to post any questions that you want to do. And I will ensure I pick out the themes from that, not the exact question, and present it to Tal as we progress through the webinar. For those colleagues who have already posted their questions to me, please don't worry. You don't have to repost them. I have already got them printed and ready. They will be presented to Tal. So, without further ado, Tal, what a pleasure having you on this webinar. And may I hand over to you now to share some of your thoughts?
Oh my God, thank you so much, Dr. Mahmud. That's I've got stopping myself from having tears running down my chubby cheeks. Thank you so much. I think the primary care has always been the poor relation of healthcare, if you look at it in almost anywhere in the world. But I think we ought to be proud of some of the things that we do in the UK, actually. If you look around at different parts of the world, Singapore, Cuba, and the UK are leaders in primary care as a specialism. And actually, if you look at World Health Organization data, then uh, productivity or economics of healthcare is actually, primary care is the place to look. So generally, health is want to have strong primary care. I think we're fortunate to to have that here in the UK. I think you're right. There is an inequity with in healthcare systems. So of course, primary care can have more, but I'm not here to argue that case. I'm here just to say what is it that we can do within what we're doing and deliver the sort of care that we'd like our friends and family to receive. I think there's a lot of things that you can do without a huge amount of resource. So today, I'll just talk through some of the things that we've done without like a mass resource. And the idea today is to not do big policy things, but to actually look at hands-on examples. And what we'd love you to do is think about how you could perhaps take away one or two ideas that you can go and actually do yourselves in your organization. So I've got a little Kahoot. So some of you may or may not be familiar. Humor me. Um, um,
Tal,
hopefully you can see.
Tal, we're losing you.
Can you see my Oh, can you see my screen?
I can't actually. You're frozen. Holly, is that for you too? You've started moving at least now, Tal, but your screen is not shared.
Oh, let me just stop. Let me try that one again. You see,
Hi, Dr. Tal. Unfortunately, that's not shared as of yet. I know that you had it before, so it might just be worth having another go. Your internet is a bit slow, I'm afraid.
oh dear, technical problems, first world problems. Can you
Here we go.
see
It started
that?
to share
Yeah,
now.
Oh,
It's just coming up.
it's
Oh,
it's this.
hold on. There we go. It's just loading,
is
Dr.
it
Tal.
It's still loading, Tal.
I might give me 1 second. I might try some.
The music's playing.
That's that's something. Let me try one last time. Uh,
Yes.
yeah,
Yeah, I can see the screen now.
right. So, those of you not familiar with Kahoot, just as go to kahoot.it and then put in this PIN number, then we can play a game. Look, it's 7 o'clock in the evening. You're all probably exhausted, and it'd be nice to entertain you a little bit and get you to play a little game for fun. So if you take either on your phones, you can use that PIN number and then put your name in. You can put your own name in, or you can put in a fun name. And then hopefully names will start to appear. I'll give you a minute or two for that. Is that have I lost
Yeah.
you? Yay, Dave, congratulations. You're the first person. Whoever comes in first wins an extra prize. So a little round of applause for Dave. So people are coming through slowly. Sorry, my internet is a bit dicey. You'll be able to join this anyway throughout later on. So the way Kahoot works is that the quicker you type in the answers, the more points you get.
So there are people who are saying they can't do it because they are using the phone to watch the
Oh, don't
webinar
worry,
itself.
that's fine.
So
But we'll make a start. Right. We've got a fair bit to go through, but let's go. Right. So dun dun dun. So this is just a test. So we're going to talk about innovation in primary care and how we can improve productivity. So here goes. So today we're going to talk a tiny weeny bit what productivity is, talk about innovation labs, which is something that we've been doing locally in our practice and in our PCN and thinking about doing it in the INT, using social media, use of AI, and a little bit about a work experience program. Right, just how are you feeling? You must be tired. Just type in how you're feeling at the moment. You've got 15 seconds just as a practice to get you warmed up. Oh, things are coming through. 15 answers, 17. To 1 second. Energized? Energized at this time of night? Well, excited. Oh my God, Dr. Mahmud, what amazing people you have here.
I told you.
What is your role? Just can be just roughly what do you do? So we got a rough idea of the type of people in the audience. Dum dum dum. 3 seconds. 2, 1. Ba-bum. GP. practice manager, change agent, clinical research, mental health nurse, digital transformation. That I love that. I love the fact that it's a mixture of clinical and non-clinical roles, and the fact that um, there's a wide breadth of roles in there. So,
Tal,
what's
can I just
productivity?
interrupt for Tal, can I just interrupt? Will you please repeat the number? Some colleagues are asking me on the question session if they can repeat the number of Kahoot because they couldn't get
Oh,
in from
sorry,
the.
it's right at the bottom. 776 739.
There you go. Thank you.
776 739. So yeah, good, increasing outcomes. So you'd think that, wouldn't you? So is the NHS on course to reach its productivity target at the moment? This one you do get points for. So you want to answer quickly and correctly. 5 seconds. Oh my goodness, you guys are on it. Uh, is the NHS? So Adil, you're getting good marks there. This is a little cutting from the FT yesterday, which says that basically productivity is worsening in the NHS. I'll go through what it means in just a moment, but basically, productivity, you look at inputs and outputs, and often that is done in orthopedic wards. It's not done in primary care. There are lots of problems with productivity. So the big challenge is that the government has said, oh, we're going to give tens of billions of pounds, something like 30 billion pounds to the NHS, and that has to be linked with productivity gains, improvements. And it's a hard thing to measure because actually productivity doesn't account. It's been done on orthopedic wards, but it hasn't really been done in mental health and it hasn't really been done in primary care because there's no easy way of identifying prevention, for example, and also the quality of care that you deliver. So the productivity measures should include inputs and outputs, but actually looking at staff wellness and also patient outcomes, as well as things that don't happen rather than counting activity. I'll talk you through that a little bit more in a moment, but about us, we're a GP practice in your northwest London, as opposed to where you guys are, but we uh, work on three broad areas. We've got innovation, research, and teaching. And the big thing, as Dr. Mohit mentioned, was equality. Oh, that's my son, by the way. So that's one way of introducing things for free in primary care is take photographs of people around you. So, but we're really committed to kind of going to try to kind of give people an equal chance. And I'll show you some examples in a moment. It's not just a word. Equality has become fashionable, really. And I think when you feel a bit sad and a bit down, and you think, oh, the government this and that, and this and productivity, have to work harder. Actually, go back to when you first came into healthcare, and think about why you went into it in the first place. And actually, when you reconnect with that, a lot of the strategy and other bits and pieces fall into place. Anyway, tech innovation, we've got a little robot. We do some patient engagement stuff. We do some process improvements and mapping things. When we do online surveys for just our patients, we get 3,000 responses in 3 days. And the only way you do that is by actually making the questions easy for the patients to do. We make videos off the back of that. But what we also do is actually really listen to what the patient's saying and look at how we can improve what we do. We obviously look at research. So because we're in primary care, we really don't have the skill sets to get involved in research, but we're working with Imperial, other partners who are research partners who help us to kind of get some evaluation and some data so that we can measure the impact that we're having. Interestingly, we're working with the King's Fund at the moment to hopefully to look at how productivity can make a difference to improve health outcomes. And then teaching, we support both patients and clinicians. And then we also have partners like that. That one there is from in the middle is where we work with Brunel University Medical School, who gave us people from, you know, people who find it hard to get work experience, opportunity to go into a medical school and speak to the dean. Right, this is a little bit about us. Hopefully this will work.
Welcome to IOS.
Is that volume low?
NHS GP practice, and I'll share some of the things that we're doing for people with. Come with me. Let's say hi to Maria. And sometimes we do group consultations for patients for diabetes, either small groups of about 6 or larger groups of up to 100. And we use data to look at what patients are interested in, and we learn a little bit about what they do and who they are. And we also have a studio where we do lots of webinars. We also put together social media content. We've bundled up all this content for you so you can access it really easy. Everything to help you with diet and diabetes.
And so what we do
like and
is we
subscribe.
basically use these test cards and learning cards, and we try to spend a lot of time actually looking at what patients want and trying to match the services that we provide off the back of what they want. And actually, interestingly, there are lots of emotional aspects that for patients that we need to think about, and little things like hi and bye and making people feel valued. I won't show you this now, but we use this business model canvas. I'm going to skip this video, but what we do
Every
is we
day,
build out
companies
personas. So these are based on the CQC personas. So pretend people, and then when we look at a problem, we try to say, oh, how would Ethel access a service, or how would Danny access a service? And it's really important to think about younger people and older people, and so the 6 demographics are the elderly, young people, working age people, those with chronic conditions, mental health, and children. And we've worked, actually, the behavioral insights team came along. David Halpern, he wrote this book here, The Nudge, Inside the Nudge Unit. So making small changes and trying to make things easy, attractive, social, and timely for patients. And that results in more engagement. Off the back of looking at different data and stuff, we've come up with some key strategic objectives for our primary care network, which is a group of practices working together. And then we basically collect evidence, and we kind of, as a group, we work to deliver different types of care. One thing that we're doing is we're moving away from the one-to-one model to large groups of both online and face-to-face, and actually it seems to be working. So having small interventions for large number of people, and we're working with lots of different people. Obviously, we're working with Chelsea and Westminster NHS Trust. We work with the schools and colleges, Brunel University, football clubs, voluntary partners, but we can go out to those places and they can come to us in primary care. In Northwest London, it's probably similar to Northeast London. We're about 2.4 million people, and the primary care networks are groups of practices that work together. So our primary care network of 8 practices covers a population of about 70,000 patients, but we work in Hounslow, which is 300,000 patients, and that plugs into Northwest London, 2.4 million people. The key thing is trying to get to work with each other, basically. So trying to work with our, the usual 5 organizations are primary care, secondary care, mental health trusts, community, and local authority. And I think we're starting to kind of get there. So there's a big push to deliver integrated care, and there's lots of benefits of that. So we're all often got the similar objectives, and we can help each other out if we do work together. And actually, the Holy Grail is trying to work on prevention. And there's an argument, we think, which hopefully we'll get some evidence for, to say that working on prevention reduces acute demand. So a lot of people think, oh, I can't work on prevention. I haven't got time for that. I'm too busy with current demand. But unless you do that, then your demand will increase over time. So there's a number of ways you can improve productivity. One is looking at the models of how you work with each other in a meaningful way, not because you have to, and then and supporting innovation and technology. Just to give you an idea of the scale of what we're trying to deliver. So this is 70,000 patients in 2 months' time in our primary care network or our integrated neighbourhood team. We've got a target to reach 6,000 children and young people, childhood obesity, vaccination, employment, 3,000 women for gestational diabetes and cervical screening, and 2,000 people in working age people. So in 2 months, we think, using different methods, we can reach, like, my maths isn't great, so 11,000 people. So one thing we're doing, we're going to go through those 4 little areas. So we want to reach out to patients on platforms they already use and try to make an emotional connection with them. So here's a quiz. What percentage of online activity is used using health apps? Is it 15%, 40%, 80%, or 100% of people use health apps online? 5 seconds, 4 seconds. A lot of people said 40%. It's a lot lower than you think. Let's have a look. Who's in the lead? Adil's smashing it. And Dave, who's the first person to log in, is rising, catching up slowly. All right, then. What percentage of online activity is using social media? 15%, 40%, 80%, or 100%? 5 seconds. Yes. So that is interesting, isn't it? So actually it's 80%. So I suppose what we're trying to say is, whoa, is firing up there. Where's Dave gone? It's gone. I'll try to fix it if I can. ONS data, Office of National Statistics data, said 15% of online activity is health apps, but about 80% is using social media and stuff. So what we're saying is, actually, instead of asking patients to come to us, be it in our premises or online, why don't we go to where they are and talk the language that they talk and engage with them in a meaningful way, and not necessarily take ourselves too seriously and not make people feel bad about themselves? Just kind of really understand what they want to do and support them. So, quick question. Do you guys use social media for personal use? Oh my God, it's really fast. Interesting one. 5 seconds, 4, 3, 2, 1. 3 actually don't use it at all. So that is interesting. But look, the evidence is there. So if you're using social media, why aren't we as organizations using it? Because you are using it at home. So do you follow? This is a tricky one. Do you follow? Sorry, I should say Northeast London. FT. I've spent too long in Northwest London. Do you follow follow NELFT social media channels? True or false? So that is a question you have to ask yourself as an organization. So you just said that you all use, a lot of you use social media, and then but you're not really, so maybe we need to think about how we as organizations use social. Oh, getting back. So we're partnering with YouTube and looking at how we can support organizations to kind of engage more with patients. And there's an argument that actually that can help to reduce demand. Right. Which some media channels do you use? I'll tweak the presentation. I'll do video with, so just ignore that part. That is interesting. TikTok is lower than I thought. Facebook is there. Fine. Okay. What is stopping you, your organization? What is stopping your organization using social media? So I think there's some, we won't have time to pick up on a lot of these things. Actually, all these reasons are, we often sometimes hide behind confidentiality and stuff, and having a clear strategy as to what you should and shouldn't post and the rules around it are already out there. The GMC, other organizations have some rules. So actually we can get past most of these things because your people are using it anyway. So, but there's too noisy, there's too much going on. You can't keep on top of it. If you look at, this is a bit of an old slide, but if you look at organizations, Chelsea, Westminster, Imperial, Barts, Guys, basically their own staff don't follow this is the number of staff they have. 22,000, 16,000, 14,000, 6,000. Their own staff are not following their social media channels. And then you got Ronaldo, who's got like billions of followers. Right, I'll be really quick now. So we look at use social listening tools to look at what people are talking about, and then we put together content which is relevant to people, whatever they're discussing. We put together some articles and some podcasts and other bits and pieces to try to understand what people want. So I'm gonna, and we reached about 1.2 million people on just TikTok alone. I want to try to get across one concept of trying to not just use social media to state things, but maybe to tell a story. So this is one about domestic violence or domestic abuse. And instead of reading lots and lots of documents and data and this, that, and the other, we built out a story. So that's my wife, it's my son's voice. So to build out a little story to try to get your message across. It doesn't have to be a complete picture, but you can pick out elements that can help you get across your message. It's got to be an emotional element to it.
Mummy takes me to the park and plays football with me. I like it, just me and her. But in the park one day, she met a new friend. I suppose he's nice. I mean, he buys me my favourite ice cream. That makes me feel happy. It's a bit weird though. He's always asking Mum for money. That makes me feel funny. I'm not sure that's okay. and sometimes he gets cross with her and me. That makes me feel sad. I'm not sure that's okay either. I sometimes wish it was just being her again, like the olden days.
Right. Can you think of an idea that you could use for social media in um any idea? It don't need to be that personal. It could be something simple. You guys know what's going on. I think all of those are really good, and we won't discuss them now. But AI, let's move on to AI.
Sorry, can
How
I
can
just come
AI?
in, Tal?
Yes.
Will it be long because we are at 20 minutes left for the whole
Oh,
session?
okay, yeah. I'll tell you what, I'll skip this bit. So I'll just go through some bits and pieces. So let me just do that. So basically, employment and education are massive factors for poor health outcomes, and we provide online and face-to-face work experience for children who can't access NHS work experience, and actually that helps to improve health outcomes in the long run. Can you think of anything that you might want to do today? Oh, tomorrow. It's a bit late now, isn't it? Any ideas for what you might want to think about doing in your organization? 2 seconds. Walk the dog. Cookery is a massive one. Mental health, AI, moreover, tech swimming. I just want to, last video takes about 30 seconds. It's quite important. You've got to just test and try things and be okay to fail, but also you've got to have a bit of determination, and you've got to work with other people in your organization and outside your organization. Sometimes things seem impossible to do, but they're the things that actually are worth striving for. This is an advert by Nike about breaking the 2-hour marathon. And actually the fact that it's never been done before is something that drives them on to do it.
Breaking the 2-hour marathon barrier is impossible. Everyone knows that. History knows it. Science knows it. Anyone in their right mind knows it. It's crazy. Nobody can run that fast for that long. So, we're doing it.
So let's see who's won. In third is MM. Congratulations. Gary came second, and first is Adele, we had a storming start right from the beginning. And the runners-up were me. Right, I think
Oh,
I'll
thank
stop.
you. I think it's probably one of the most interactive sessions we've had on this webinar, and it's really good. But what it did do was brought out the power of using technology in a way that people feel engaged. And you know what I really liked was you used this term, how do you use how do you manage to use technology and still keep the emotional connection? That's what this particular session so far demonstrated. You can keep people feeling active and being part of something and engaging them, but yet giving power back to people. And that's what health's all about, isn't it? I mean, I'll be honest, I don't want someone telling me how to manage my diabetes. I don't want someone telling me how to manage my leukemia. I want someone giving me the tools so I can manage it around my life in a time that suits me and works for me. Because if it doesn't work for me, then there's no way I can manage. I'm dependent on others and I want to be independent. There are some really good questions, but I'm going to pick up the first one because it's my prerogative, guys. Sorry, I'm the host. So, using technology, using social media, using this is not about the tools of social media. It's not about technology. It's all about the culture of adoption, of trying something new. And you use the term, it's okay to fail.
Mm.
You are part of a large practice. And primary care traditionally is funded to do certain things, and people are so busy with their head down. And I completely agree that it is wrong to say, I can't do this because I don't have the time. Because actually, if you don't find the time to do it, you will never get free. That work keeps piling on. But clearly, today you've shown that by one consultation, you can do 100 patients rather than having to do 100 consultations for 100 patients. The question to you, how long did it take you to change the culture of what you're doing within your practice? Because I want people to sit back and take heart and not get scared that they can't do it next week. And so they are worried they failed.
It's a really, really good question. And that concept, look, we're not in healthcare, we don't like failing because failure is a bad thing. But if you look in other industries, certainly I did a visit to Google and I did an MBA and a part of that was a visit to Google. They give their engineers 1 day off a week to work on innovation projects. 90 odd percent of them fail and they want them to fail. If you're not failing, you're not pushing yourself. And but you can say that until the cows come home. You tell people, I want you to fail, I want you to fail, please fail. You know, I think who was it? Facebook had Mark Zuckerberg had this thing about um, test things and break them. Basically, you want to break them. We're not psychologically, we're not geared up for that way of working. And even when you give permission, so what we did is we looked at people's rotas and times, and we said, okay, and meetings and stuff. For example, if somebody wants to work in diabetes, then like a diet and exercise, then what we can do is we can bring in other dietitians, we can bring in admin people, we can bring in doctors, nurses, we can bring a whole bunch of other people who've got shared sort of project that they want to work on, but they have lots of different inputs and insights into it. They're still a bit scared about failing. And I think you just have to support people to kind of test and try things that they wouldn't necessarily be comfortable. If you look at the reasons that were quoted today around not using social media, I bet you if you were to put together a little plan of what you might want to do, you can type it into ChatGPT and say, come up with a social media strategy. Like it can, and then run it past your manager. Your manager say, okay, people are using, you've demonstrated yourselves today that you're using that at home. Now that makes you quite good at it and you know what works and what doesn't work. All I'm saying is, why shouldn't the organization benefit from that? The organization can, what we found is there's so much talent already with embedded in, we just need to allow them to kind of have ideas and develop them a little bit. You learn new skills.
Yeah.
People are interested in research. We give them the opportunity to get involved in research. So
And how long did it take, Tal, for this conversion?
it does take a little while. I think I think for us as a practice, we set up these innovation labs. We half a day a week to work on innovation projects. We looked at data and stuff, and we said these are the areas you want to work on. It took us probably about 6 months as a practice. We did that as a primary care network, which is a group of 8 practices, and we've set that up now, and that's probably taken about 3 to 6 months as well. So to get them functioning and get people working and talking to each other is about a month or so, 6 weeks. To get them to get to something productive, I think now is another. So it's not that long, but what they're doing is big problem that healthcare professionals have is that they're burnt out, they're like exhausted, and actually doing a group consultation with other healthcare professionals with a group of patients. One of the things that we look for as a good outcome is laughter. So actually, you being able to work with somebody that you wouldn't normally work with and talking to patients, stories sharing. And our job in those group consultations isn't to tell people, to teach them, it's just to facilitate, exactly as you said.
Yeah.
Patients are already experts in that area. They can just share their own tips and we're there to kind of facilitate more than anything else. So I think for the people in this webinar today and leaders of organizations, it's our job to create that space for people to be able to work and to support talent, and for
Absolutely.
people in the organization to kind of take that opportunity. You don't force
And
anyone. You just encourage.
absolutely, absolutely. And I think it's a really helpful thing. I think the time frame gives a feel of let's not be in a hurry, but let's be clear that you have a trajectory and a way of working towards it. And that's more important. So there are a couple of other questions about language. And I know you work in a multicultural
Yeah.
area because I know your practice and I know the area. But Tal, talk people through how you use different languages in your social media messages so that they can also think this through.
Well, one thing that actually, if you look at public health, so public health has formal English language, right? But that's not, I remember once we were asked by public health to translate a document during COVID time, do video in Urdu. Now, the first of all, our staff are like the United Nations anyway. So there's people who already speak millions of that language. Anyway, they said, "Oh, could you translate this into Urdu?" I said, "Yeah, okay." Then they gave a script, but it was formal English. And so the doctor said, "Oh, I have to Google up the Urdu words to kind of
I think you're frozen again, Tal.
that people use themselves, not, so use slang, use language that people actually use. And AI now, actually, there's something like YouTube has something called dubbing, which is they're slowly releasing. So you can do a video in English, and if your web browser is Spanish, it will basically dub it into Spanish or any other language you want. So
And I,
I think we often get stuck on a direct translation from one language to another. Actually, it's much more sophisticated than that. It's the dialect, it's the tone, it's the it's the words that you use are different. You can't do a direct translation.
I think the point you make about using colloquial language is a really good one because often we get stuck in using the Queen's English or using language that is very textbookish, but it doesn't resonate with the people who need to really feel that it is their language being translated. And I think you have some fans also in our club who are talking about the work you're already doing in your PCN. So well done to that.
Thank you.
Some really good feedback of the work you've done and the positive outcomes it has had for your patients. I think John raises a really good point in the question. He talks about using AI to determine the top 100 primary care conditions and then using your videos basically to freeze that. And I think that's a really good point, John, you've raised there because colleagues, we are not just in the place where we are only learning from our speaker. Many of us would be sharing our experiences, and together we become a stronger community. There are almost 100 of us just on this particular browser right now. And you can imagine that 300 overall, you've got people in different other browsers. So, John, thank you for that point. It's a really good one. I think there is something about a colleague who has raised that it's wonderful to hear all these statistics and it's wonderful to hear what's being done, but I am not getting access to my GP and I'm not getting access to my same GP. So there's this continuity that primary care has always been the bastion of primary care. Let's be honest, that's where primary care has built its strength. And I think rather than presenting that question to Tal, I will say upfront, you are spot on, and I'm sorry that that's the experience you have. But I think it's not just the practice that does it. If we take a step back, we will recognize how often, like the figures I quoted, we are not using all the appointments that are given to us. We don't turn up. There are missed appointments. There are patients who are attending practices who really don't have to go to see a GP because actually many of primary care conditions can be seen by the local pharmacist, can be seen by other, and we often tend to use the services in a way that works with our lifestyle. And I understand that. Don't get me wrong. I'm not trying to say people are wrong because that's never the case. That's how people are. And I am like that. And all of us are like that. But if we really work this through along with our practices to have a genuine conversation to say, talk us through why are we not being able to use the appointments the best possible? Because the conversation then doesn't start from the place of, we don't have enough appointments. It start with the place of how do we make best use of the appointments that are available? I think we will often find that practices get caught up with so much of same day onslaught, which doesn't have to be them quite often. And that freed up time gives a much better appointment for colleagues who have raised with long-term conditions, because actually that is where the strength of primary care comes in. It's not the same day appointments. It is actually in the long-term conditions management and avoidance of conditions to become. So it's the prevention, both primary and secondary, where there is no one better than G or GP practices to work with.
Yeah.
So my colleagues, I would like to say, if you think it's not working, become an active member of your PPG, get involved, because you have the best place then to work with your GPs and to find the right answers. Because I promise you, I have never in my 35 years of being a doctor come across a GP who doesn't want to do the right thing. So work with them, and I promise you they'll do the best.
And I'll just quickly chip in, Mahir. I mean, that is always a trade-off, isn't there, between continuity and increasing demand. If you use technology and groups and consultations and support, do prevention work, actually, there are two groups of people. Group who don't, they've got a sore throat, they need to be seen, they just want to be seen. And then there's people who with long-term conditions, as you mentioned, who do want to see the same person. I think if we can find ways to improve the service we provide, giving patients what they want, then actually it frees up more appointments for people who do want their continuity. So it's not 100% of patients who want continuity. Yeah. Actually, it's a fraction. And the AI thing you mentioned as well, I think we're working with a company called Q, which is, and we're looking at how it can triage calls, it can ask patients what they think. It includes a bit of empathy. It's signposting, embedding videos into it. So there's a whole bunch of tools that can help, but that's not for everyone. It's for some people. And those who want to come in for a face-to-face, we're also doing care plans at the moment. So some of our more ill patients, we spend half an hour with them, and they spent, I've done that this afternoon, and they're patients that I've known for 20 years. So I think it's a try. That's why you've got to understand what patients want. And some patients absolutely want continuity, and some patients are absolutely want to be seen immediately by anyone. So you have to be able to accommodate both. But technology can help you to sift through that volume of work in a way where you're not feeling frazzled. So you're more productive, but actually you feel happier about yourself. You can deliver on your personal goals around education, research, or teaching. And also you're happy, and then it's better for patients.
So I think if I may just come in, Tal, I think we are running out of time, and there are a number of questions that people have still asked, but there is one question I'll pull out from that. And Adil, I'll not ask your question because you've already won one of the awards I think that Tal was giving. So I refuse to get you, but that's not fair, Adil. So hear me out. But I'm going to ask this question that Cynthia has posted, which says about social media phenomenon and influencers. Do you think there's any benefit in adopting healthcare professionals using this phenomenon of using influencers to make a difference to this?
I
Six
think
views.
that healthcare influencers are fantastic people. They're making that argument, and some of them are, you know, amazing. And you know, the thing I'm trying to get across today,
Value frozen again. Right.
talent in it, and we need to think about how we can get an organization to use it rather than an individual. So of course work with influencers, all the rest of it, and but an organization can actually reduce its demand.
I think, Tal, how should I summarize today's session? Wow, would that help? I think it's been so different. You know, it's been so interactive and yet so different. And you brought the power of using that for us to experience as 300 people strong what we can possibly do with our registered list size of 10,000, 15,000, 18,000, 20,000, or 60,000 if it's a PCN we are talking about. And I think it has been brilliant to hear some things like using the power with large groups on face-to-face online consultations, working with churches, schools, voluntary sector partners. I think what was really strung me was the bit about you making an emotional connection. So there's a question about how do you keep it personal? Well, we did keep it personal by just picking up things that make people come back to say that matters to me, and you're picking up something that matters to me. So thank you. I think there was something around being okay to fail. So I remember this thing from Dyson because he said that it was his 10,001 vacuum cleaner that became, and today, so he failed 10,000 times before he created that first vacuum cleaner. And today, there is no one who doesn't want a Dyson in their house. I mean, it completely depends on affordability, and it's getting out of range for even me right now. But that's the reality of life. That is the number of times you fail before the success comes. So I think um, when over 300 people participate in something like this, and they are absorbed in such an important thing around AI, digital innovation, technology, use of social media, I think you know you've hit the nail on the head, Tal, today. And that has been absolutely brilliant. And someone like me in my 50s, who I refuse to admit I'm in my 50s, so guys, don't quote me again on this. But for someone like me who is not the most digitally savvy, I'm very comfortable doing my stuff, but I'm not the most. Even I found it something that attracted me to it, to make me feel, come on, let's try something new, because that's the way to reach people. And it also goes back to the question of how do you become more productive as a service without actually having to work longer hours and harder hours. And this was really inspirational. I found it, in fact, I was jotting down some point to say, we're going to take this back and to try these things out, because that's really good. And I think, Tal, it's a big thank you to you. I really can't say enough about how you have merged your, without a doubt, your personal effusive passion for technology with your professional curiosity of medicine to make them come together and create this very different niche of how you can make a difference. I think many of us will learn from this today and take this back. And I think it was brilliant to have so many amazing people online participate and get awards. Of course, I'm a bit sore with you all that I didn't top in the top podium, the top three, but I will still take on board. It was wonderful to have so many of you register for these webinars, because actually without your participation, these webinars become meaningless. Having the best of guests makes it meaningless. And 300 of you participate, when there are 2,000 hits to each of these webinars throughout the end of the month, you do know some people are going to pick up. And that means so many more patients, so many more residents will get better care, which is why I started this in the first place. And it really makes me happy to see that happen. Colleagues, the next webinar will be on the 19th of March at 7 p.m. again. A big thank you also to Holly, who, in the background just makes this look really simple and easy. But believe me, she's fretting on multiple screens trying to invite people, get it done. So, Holly, thank you. It really wouldn't have worked. And I'd be very grateful if colleagues would take a minute to just quickly scan this QR code and fill in the feedback form, because it helps us keep it live for you and meaningful for you. But thank you everyone again for today, and I hope you have a wonderful evening. Take care. Holly, will you stop?